Good afternoon, everyone. My name is Andrew Smith. I am the head of the Living Well team at the Leukaemia Foundation. A huge thank you for everyone for joining us today on World MPN Awareness Day. A huge shout out to our sponsors who have made this event possible. Today's event is a partnership with the MPN Alliance, and we're joined today by members, consumer advocates from the MPN Alliance, Sue Taylor and Ken Young. A little bit of housekeeping. We have 4 presenters today. Each presenter will talk for roughly 15 or 20 minutes, and we'll leave some time at the end of each presentation for some questions. You will see in the toolbar below that there is a function where you can ask a question, pose a question. So we'll be monitoring those and publishing those for each presenter to answer at the end of each session. All right, so without further ado, we might kick off the session. And it is my great pleasure to introduce Professor Andrew Perkins. Professor Perkins is a clinician scientist and professor in the Australian Centre for Blood Diseases within the Central Clinical School at Monash University. He heads the Perkins group studying blood cancer genomics. His group is interested in transcription factors, how they work as master regulators of lineage to identify and how mutations in them result in genetic disease and cancer, particularly blood cancer. To study this, the group employs state-of-the-art genomics techniques. They have a long-standing interest in the genetics of myeloproliferative neoplasms, MPNs, particularly the JAK-STAT signalling pathways and how it regulates gene expression. They've been extensively involved in clinical trials of JAK inhibitors in MPNs and are interested in developing new therapies and biomarkers to improve outcomes in this difficult group of blood cancers. So please welcome Professor Perkins.
Thank you, Andrew. Welcome, everybody. I hope you can see the screen. Tell me if there's any issues. So I'm coming to you from sunny Melbourne today in lockdown. The picture in the background's not from Melbourne, it's where I'd rather be. But I'm enjoying the opportunity to share some time with you. I want to thank the Leukaemia Foundation and MPN Alliance for the invitation to share the morning with you. These are my details. This is what I'm going to talk about today. I'm going to remind you what MPNs are and what causes them. We're going to talk a bit about prognosis and a bit about treatment. My focus will be on the worst of the MPNs, myelofibrosis, because that's where we need better therapies and more intervention and more understanding. But so I apologise to those of you that haven't arrived at that myelofibrosis destination yet, but you may or may not one day be there. So what are MPNs? They're a heterogeneous group of diseases. Many of you in the audience will have either ET or PV, essential thrombocythemia or polycythemia vera. I have these on the good end of this spectrum of MPNs, and they can progress to worse MPNs such as myelofibrosis over time. And myelofibrosis itself, if you're unlucky, can progress into what we call accelerated myelofibrosis or even acute leukemia. And this has a poor outcome. But MPNs, for a hematologist, overlap with another group of diseases called the myelodysplastic syndromes, MDS. And some of them are actually, a little tricky to be sure about whether you have an MPN or an MDS or a bit of both. So we'll touch on how to be sure about this in a minute. So what's the basic underlying problem in MPNs? It's basically that you have too many blood cells. So here's a schematic of the bone marrow where the blood's produced. And if we look inside the marrow, then there's this factory. In this case, I'm looking at the red blood cell factory that produces from a stem cell a certain number of blood cells in a certain amount of time. And these are then exited into the circulation. In MPNs, the factory is working too hard. and we get too many blood cells. And the reason we do that is there's two fundamental problems. One, there's too much proliferation, and two, the cells live longer than they should. Their normal suicide timing is off, and they live too long and cause problems by being there in excess. They clog the circulation, cause vascular events, and eventually myelofibrosis. So another way to think about myelofibrosis is to understand how the factory actually works normally. So this is a schematic of a blood stem cell in the bone marrow. This is the outside of the cell and the inside. And the cells have receptors on them that respond to growth factors. And these growth factors include things like EPO, which is topical at the moment with the Tour de France on. It's the drug abused by the cyclists, of course, and myeloid and other growth factors, including thrombopoietin, which stimulates this receptor. Now, when thrombopoietin comes along, the receptor undergoes a change, and this protein you've probably heard of called JAK2 sits there quietly underneath the cell membrane, and when the ligand binds, there's a twisting action of the receptor, and JAK2 becomes activated. Then when it's activated, it turns on other proteins, in particular the proteins called STATs, and these are clever proteins. They sit quietly in the cytoplasm until they're activated, then they jump into the nucleus of the cell, bind to DNA, and they turn on genes. And it's the genes they turn on that actually cause the excess proliferation and the prolonged survival of the blood cell. So if we understood what these genes were, we'd understand MPNs much better. Now, there's three key mutations that drive MPNs. The first one is a mutation in the JAK2 gene itself. So this mutation results in the cell thinking that it's seeing a growth factor, but it's not. So we call this constitutive activation of the signaling pathway, and the cell's confused. It thinks it's got a signal to proliferate and a signal to survive when the actual signal's not even there. And so this mutation is similar to having a large dose of a growth factor. The other important mutations that you may or may not have yourselves are in CALR, which is a gene involved in how the receptor gets to the surface, or in the receptor itself. So this is the natural history of MPNs. In the chronic phase, the disease is very quiet, but eventually we have a risk of dying either of old age, which is what we want, or mostly vascular events. So the treatment in this situation is to prevent the vascular events. It can progress to myelofibrosis, in which case we have other issues. And also there's a potential progression through further mutations, eventually to AML and bone marrow failure. So how can we change this history? We really want to stop vascular events in the early phase, and the treatment here is aspirin and hydroxyurea. We want to try and prevent chronic phase becoming myelofibrotic, so we want to stop this. The best drug we have at the moment is interferon, or Pegasus, a type of interferon, and we want to stop myelofibrosis causing progressive disease. So here we have ruxolitinib, Novartis drug on the PBS. And lastly, we want to stop progression to leukemia. So here, if you're young enough and fit enough, we have a bone marrow transplantation option. But otherwise, we're talking about trials, because we don't really know how to prevent this very well. All right, so I'm going to step to the side slightly and talk about next generation sequencing, because it's what I do. And I'm going to tell you why you might want to ask your doctor to get this done. In Melbourne, there's 3 major hospitals that do it, but all the capital cities have the potential to get NGS done. So you might want it for diagnosis. Remember I said at the beginning, sometimes it's not quite clear whether you have early myelofibrosis, ET, or some overlap syndrome. A molecular characterization through NGS will help get to that point. It's very important for prognosis, as I'll show you in a minute. We're not just interested in the driver mutations. We're interested in what's known as high molecular risk mutations. These are the mutations that can predict whether you're going to die of old age or progress to myelofibrosis or even leukemia. So they're useful to know about, particularly the few that we can intervene with. And lastly, we can decide what to treat you with potentially anyway if we know what we're treating. We know what the mutation is. So this is a great paper in the New England Journal published by all the leaders in the world, where they looked at what are all the mutations in MPNs. They sequenced 2,000 cases. Here are our driver mutations that I told you about. And then these things that are at low incidence are all the other potential mutations that could happen and could influence how your disease is going to behave. This is just a paper from our lab done a few years earlier that shows the same thing. And this is some of our experience at the Alfred Hospital using NGS. So here are our driver mutations. They're the most common, but you may not have either of these three mutations, and you may have what we call triple negative MPN. And you can see in this case, it could be one of many different mutations that's responsible for your disease. Another reason to get NGS is you may not have a mutation at all. In fact, you may not even have an MPN. So it's very important, I think, to ask your hematologist, what is the mutation driving my MPN? Because it may actually be reactive, especially if it's thrombocytosis. So we find reactive cases and tell the patient they don't have cancer quite frequently. I'm going to give you an example of a case that NGS was useful in and give you a flavour of the natural history of MPNs. So this is a patient of mine, Mr. DB. That's not really his initial, but we'll use that today. He had essential thrombocythemia diagnosed in 2008 when he had a headache and was found to have a thrombosis in the brain. And at that time, his platelet count was over 1 million. He was diagnosed with ET and started on warfarin for the thrombosis and hydroxyurea. And he was well for a number of years. 7 years later, he had a vomit of blood, a hematemesis, and the gastroenterologist scoped him and found he had varices, dilatations of the vessels in the esophagus. And this was due to another new thrombosis in the portal vein just next to the liver. So nothing could be done. He stayed on warfarin. Then in 2018, he became unwell. He started to get very fatigued. He lost 10 kilograms in weight, and he filled in this MPN 10 score for me. So I don't know if you guys have seen this, but it's a useful little home scoring system for your symptoms. And with myelofibrosis, there are a lot of different types of symptoms you might have. Some of them are quite subtle, and some of them change over time with therapy or just with progression. Find out about your MPN score. Keep a log yourself is my recommendation. It was developed by Ruben Messer, one of our great friends over in the US. So this patient was investigated, found to have myelofibrosis with a large spleen and a high LDH. And we looked at his risk. This is the IPS risk score that determines whether you're eligible for ruxolitinib on the PBS. So his median survival is about 4 years. We predicted his IPS score is 2. He gets a point for age, and he gets a point for a lot of symptoms, but not for these other features. So he was put on ruxolitinib on the PBS and did well initially, but unfortunately, like many people on ruxolitinib, he progressed in about a year's time with increasing anemia and increasing problem with spleen size. So we did NGS on him and found that he has indeed the JAK2 mutation, plus 2 other mutations. One that you don't want to have is a mutation in DMT3A, a gene that predicts poor outcome. So this is one of the online prediction tools anybody can use. That's the web address. You can look up your own survival if you want by plugging in these details plus some of the genetic information that you'll get from NGS. So we did this for our patient DB and found that his 10-year predicted survival is 13%. He wasn't happy with that. He wanted to do better. So we entered him into a trial. Sorry, my slides are a bit slow. Here we go. A Novartis trial, an early trial. of a combination of ruxolitinib with one of these three agents. He got this MDM2 inhibitor. This is a trial that's available in a few sites in Australia. And he did well. He improved his hemoglobin. He didn't need blood transfusions anymore. His spleen shrank a little bit, but after 9 months or so, things went downhill again, and he's on another trial at the moment. I want to just deviate for 2 seconds, if I can, to talk about my research. It's just 2 slides here. So I think I told you that MPNs are due to abnormal JAK-STAT signaling, but we want to know the genes that are responsible for the MPN so we can find new drug targets and new biomarkers. So in our lab, we do a lot of genetics. We want to know where the STATs actually bind in the genome, and we're using a technique called ChIP-seq, looking for all these little spots this protein is bound. And then we want to understand how genes are regulated by this binding event. So we use a technique called RNA-seq. And here's just a little schematic where we've tested 4 different drugs. Just for your interest, ruxolitinib is probably the best JAK inhibitor we have in terms of phosphorylating, turning off phosphorylated STATs. So what we found is these STAT proteins bind in the DNA and they turn on a number of interesting genes. These are just 2 of them, BCL2 like 1, which includes the BCLX gene protein, and ID1. They're next to each other in the genome. This is a browser shot from Santa Cruz Genome Institute. And what we're looking at here are binding sites for CTCF proteins, which loop this thing into a big loop, which we call the survival hub. So these genes are all next to each other, and they're regulated here in the red and green tracks by STATs. So what we think happens is these STATs cause a conformational change in this survival hub, and this is how the cells understand how to respond to growth factors, or how to abnormally respond to mutations in the pathway. So this is basically the little engine that causes the MPN phenotype, or one of the 10 or 20 different engines we think exist. So this is the prolonged survival phenotype. All right, so now that we know that, and companies like AbbVie know this, we can think of new drugs. So BCL2 like 2 gene encodes the BCLX protein, and this is a pro-survival protein that turns off the pro-death proteins. Normally, blood cells are programmed to death, and because of the JAK-STAT mutations, they have a pro-survival protein that stops the death. So if we could block this protein, we could potentially re-engage normal blood production back to normal. That's the idea. So there's a drug called navitoclax, which is an inhibitor of both BCLX and another protein, BCL2, that's not really relevant to myelofibrosis. So there's a lot of preclinical evidence from many labs in the world that navitoclax is beneficial in people with MPNs, and the dream is that it could potentially eradicate or even cure MPNs. So my patient DB is now on a navitoclax trial here at the Alfred. This is just some work from our lab showing there's new inhibitors out there that are not commercially available yet, that are about 200 times or 100 times more potent than Jakavi or ruxolitinib in killing MPN cells in culture, at least. So what do we do about MPNs these days? This is our standard of care. We try and keep people with PV and ET away from myelofibrosis. If you get myelofibrosis, then if you have advanced disease, you can get Jakavi, ruxolitinib on the PBS. And you go along until you start to get resistance. And if there's progression, then you have other JAK inhibitors, all of which are available in trials around Australia. And so people can respond to switching to a different JAK inhibitor. If you go into accelerated phase, NGS plays a big role to try and work out what personalized trial would work for you. Most of these are not available, these other drugs in combination yet, because it's just hard to get such trials up and running. And lastly, if you have AML, you're in trouble and you need to be treated as AML. and have a transplant if you can. But the new paradigm is to try and intervene earlier and change this whole natural history. So this is where navitoclax comes in and where combination drugs come in. So that's really where we are in treating myelofibrosis at this stage and MPNs in general. So my time's up. I want to thank my lab, who are all pictured here, particularly, well, these three in the lab. Liesl Butler's a clinician that works for me now. I want to thank Alfred Pathology, who work with me in all the NGS funding organisations and the clinical trials unit, particularly Daphne. So hopefully that was enlightening for you. I'm happy to take questions.
Fantastic. Thank you for that. Thank you for that wonderful presentation, Andrew. I've got a couple of questions coming through. I might start off with the first one. There's a question about hydrea, and the question is, I'd like to know if there's a correlation between the amount of hydrea you take and your level of tiredness. It certainly seems to be the case for me, and now that I don't take it at all, I feel quite different. I'm on Pegasus now.
Look, I get asked that question a lot. I personally don't think so. I think the tiredness is due to two things. One, it could be due to anemia. So there is a correlation. If you're taking too much hydrea and you become anemic, then you may need to dial back the dose. You may be becoming anemic because the PV or ET is becoming fibrotic and your marrow can't make red cells anymore. So you may need a bone marrow biopsy to investigate. The other reason to be tired is the disease itself. So it's hard to really know how much is disease and how much is drug. Pegasus is a great option, and we can talk a lot about Pegasus if you want to, but Pegasus itself can cause, in some people, tiredness. The older versions of interferon, Roferon A, cause a lot of aches, pains, flu-like symptoms, tiredness. And Pegasus is much better. It's a good drug, but it can itself cause some tiredness in some people. So talk to your hematologist, see what works best for you with hydrea dosing.
Wonderful. There's a couple more questions coming through. Given the different treatment options based on the different genomic profiles of this disease, in your view, should all patients receive genomic screening to work out the right treatment options? Great question.
Well, it costs money. It's not freely available on a rebatable thing. So I think people with simple ET and PV that have at least the driving mutation understood, if they're well, they may not need it. But if there's some change in their disease, or if you have myelofibrosis, then I think you need a full panel done. But even in PV and ET, there are second hit mutations that may well be worth knowing about. So it depends a bit on cost, availability, and whether you want to know certain information or not. Talk to your hematologist about it. It's certainly available. And the cost is about $500, $600 for most, labs that are offering it.
Excellent. Next one. Andrew just mentioned Pegasus. Is there any information on when Besremi might be available in Australia? I understand the cost proposed by the makers is a key issue. Is there anything people living with MPN can do to lobby for a favourable outcome for Australians living with MPN?
Yeah, we always like lobbying. It's actually very powerful. I don't know the answer of when it will be available. I haven't been involved in any of the applications to PBAC for it. So short answer is I don't know the timing.
Absolutely. I mean, I could probably jump in there. I think both my organisation, the Leukaemia Foundation, and the MPN Alliance Australia are obviously heavily involved in advocacy for PBS submissions. So my advice would be to get in touch with either or both of our organisations. Absolutely. All right.
I mean, just to plug, MPN Alliance were very influential in bringing Pegasus to the Australian MPN community. So a big thank you to them for that.
Absolutely. All right, another question coming through. Got a few more minutes. You mentioned, Andrew mentioned DB as a retired academic. I've noticed that a lot of MPN sufferers have a reasonably high educational status and high socioeconomic status. Is there any data to support this analysis? And if so, what do we think some potential reasons might be? Interesting question.
I have the same observation. All my patients are smarter than me, I can tell you that. So I don't know why. I don't know of any data doesn't really make any sense, but it's certainly, maybe I'm just lucky and I get nice patients. I don't know.
Absolutely. All right. Another quick one. Great presentation. Lots of great presentation. Lots of thank yous coming through. Could you explain what molecular remission means in a practical sense?
Oh, that is a good question. So I don't know if anyone in the audience has chronic myeloid leukemia. You might have noticed that was on my slide and at the beginning. That's another MPN-like condition driven by a different mutation in BCR-ABL. There, we have drugs that can cure you or potentially cure you, and we talk about molecular remissions. Unfortunately, in MPNs, we have very few drugs that have a proven ability to reduce the allele burden or the molecular mutation level, which is a surrogate measure of whether your disease is being potentially cured or not. Now, there's a lot of conflicting evidence about Pegasus and whether it can do this. The old literature suggested if you take enough of it, particularly from the French groups, that it has a potential to reduce your allele burden. We can measure allele burden for you in different ways. In the case of a JAK2 MPN, we have very sensitive assays, digital droplet PCR assay, for example, that can actually monitor. So I have patients on Pegasus that we monitor what their molecular response is using a JAK2 assay. Can do the same with NGS, but it gets a bit expensive to do it every few months. But, you know, we dream of a combination of drugs that can actually eventually get rid of the clone. And we would monitor that. A lot of the new trials have a molecular monitoring using NGS to try and see whether we are actually influencing the molecular status of your disease. Great question.
Absolutely. All right. I think that's probably it for now. We've got lots of wonderful questions coming through, and Andrew might try and jump on and try and answer some of those in the chat. But my great pleasure to hand over to Sue Taylor from MPN Alliance, who is going to introduce our next speaker.
Our next speaker is going to be Professor Wendy Erber from the University of Western Australia. Wendy is a consultant haematologist and professor of pathology and laboratory medicine at the University of Western Australia, where she took up the MPN chair and head of the school in 2011. She was subsequently seconded to be Dean of the Faculty, a position she held for 4 years. Wendy had graduated from the University of Sydney and then went to the University of Oxford, where she did her PhD in leukemia. This 4-year experience set her on the path to applied haematology research in the field of leukemia diagnostics. Wendy has been active in discovery and translation of findings in myeloproliferative neoplasms. She was a member of the team that discovered the JAK2 mutation in 2005 and has published on the pathology and genetics of MPN. She's recognised for her expertise in the appearances of MPN, both blood and bone marrow, and the changes that occur with progression to fibrosis. Together with her team, she is continuing to investigate the biological processes that cause this to occur. All of this is to improve the diagnosis and care of patients living with MPN. She has more than 180 publications in peer-reviewed journals and published 3 books. She's a finalist for the 2020 WA Scientist of the Year. In 2016, she was admitted as Fellow of the Australian Academy of Health and Medical Sciences in recognition of her contributions to haematology. I'm looking forward to hearing from Wendy.
Sue, thank you very much for your very kind and warm introduction, and I wish to thank the MPN Alliance Australia and the Leukaemia Foundation for the opportunity to speak today on MPN Awareness Day in Blood Cancer Awareness Month. Good morning to you from Perth. Andrew has really set the scene for what the myeloproliferative neoplasms are, and what I'm going to do today is show you some of the pathology of the myeloproliferative neoplasm entities as they move from the chronic phase, as Andrew described, through to the more aggressive phase as the disease progresses to fibrosis. And then I'll give you some new data coming from across the world and our own laboratory of some of the mechanisms that may be underpinning the progression to fibrosis. So Andrew, thank you for introducing the entities and this overview slide showing the three main conditions that I'll be describing: polycythemia vera, which I'll also abbreviate to PV, essential thrombocythemia or ET, and myelofibrosis. The images on the right show the pathology when in sections of the bone marrow, the left-hand side being the hematoxylin and eosin stained section, and on the right, but difficult to see, is looking at the quantity of reticulin, the reticulin fibres that indicates the amount of fibrosis, as patients may, and we hope will not, progress to myelofibrosis or bone marrow scarring. So I'll firstly show you some images of what the blood and the bone marrow look like in these conditions, starting with PV. In PV, again as Andrew described, the bone marrow is making too much blood, and in PV we have very thick blood, too many red blood cells, a slight increase in white cell count, and an increase in platelets. And the large images on the left and on the right sections of bone marrow, which largely resemble what normal bone marrow looks like, but it's too cellular. The white holes here are the fat spaces, and normally about half of our bone marrow when we're adults are these white spaces or fat, and the other half is cells. And in this image you can see that most of the marrow is taken up by cells. The bone marrow is in overdrive, that constitutive activation of signalling pathways leading to too much marrow being made autonomously. And on the right is the same at high power. I'm showing you this because the only cell that is morphologically or has an abnormal appearance is the megakaryocyte, this large cell here and here and here, and I hope the arrow is working, because I'll be spending quite a bit of time when I talk about myelofibrosis looking at the megakaryocytes. In ET, or essential thrombocythemia, the only abnormality we see in the blood count and the blood film are too many platelets. These little purple dots present in this small image of the blood. And they come from the megakaryocytes here in a smear of the bone marrow from the bone marrow aspirate. These megakaryocytes, 3 of them very close together and larger than they should be. And in the section of bone marrow on the right, far too many megakaryocytes, and they are larger, which Wendy describes as large and giant forms with bizarrely hyperlobated nuclei. The purple bit inside the megakaryocytes is looking more complicated than normal. Very characteristic features of ET. These are both the chronic phase of MPN. In myelofibrosis, patients are clinically symptomatic with anemia, fevers, aches and pains, perhaps some discomfort from their spleen. And that we also see changes in the blood with variable low blood counts or cytopenia, cyto meaning low and penia is being reduced, a low hemoglobin, low white cell count and low platelet count. But there are also abnormal appearances, and I hope you can see, without really having too much in-depth knowledge of blood film morphology, I'm hoping that you can see there's quite a degree of variation in these brownish coloured cells in the background, which are all the red blood cells, and particularly looking like a teardrop. And that is a word that we use. A teardrop poikilocyte. Poikilocyte is an abnormally shaped red cell in the shape of a teardrop. And on the right-hand side, we can also see abnormalities of the white blood cells with immature cells that should normally be in the bone marrow that are now in the blood, and a very abnormal platelet, which is really giant and has abnormal granulation. And all of those features are what we see in myelofibrosis. When we take a bone marrow sample, we also see abnormalities. The first point to note is when you have your bone marrow done, if the doctor is unable to aspirate or suck out any bone marrow, that's a bad feature, and that generally indicates there is too much reticulin or too much fibrosis holding that bone marrow inside the cavity, and even with the force of suction on the syringe, being unable to aspirate any bone marrow. So that's a bad sign. Often the only sample we have is the biopsy, which is shown here on the left. Now, if you remember the images from the previous two, PV and ET, I hope you can see that this looks rather different. The staining is a little darker, and that's not because we did anything different to the staining, it's because the nuclei, the purple bits inside these megakaryocytes, is very condensed, really compacted and giving a darker stain. And that is a feature of myelofibrosis. In addition, here we have a group of megakaryocytes near this shard of bone or bony trabeculum. These megakaryocytes are in the wrong place. They shouldn't be there. They should be in the middle of the bone marrow near the fat, not near the bone. And also, they're looking after each other in this cluster. There are 4 or 5 of them here together, and that clustering is also an abnormal feature that we see in myelofibrosis. So as it says in the words at the top, the bone marrow has increased cellularity. It's very disorganized. The pattern, the location of the cells is abnormal. There's an increased number of megakaryocytes. They are in groups or clusters, and they're near the bone. And that is then associated with an increased number of fibres, the reticulin fibres, which now you can see at higher power compared with the first slide I showed you. These black lines, it's a different stain from the one on the left, these black lines are the fibres of reticulin, the reticulin fibres, and when they're in parallel strands like that, making a very wide band, may form collagen. This is significant scarring of the bone marrow, and it's because of this reticulin that we can't aspirate any bone marrow. This is an overt case of myelofibrosis. And it can progress even further. The bone can be involved as well, and at this stage, which is really the end stage of myelofibrosis, we call osteomyelosclerosis. Osteo meaning bone, myelo is the marrow, and the whole thing is looking very sclerotic or fibrotic. And the image in the left-hand side, you can see, I hope, that these big pieces of bone which are present within the marrow have thickened compared with normal, and it has narrowed the amount of space where bone marrow can grow. And as a consequence, at this very end stage of the disease, the patient will have very low blood counts due to inability to make marrow. On the right is the reticulin stain of this case, and there are a lot of reticulin fibres lining up, and it's really encasing every single cell in the bone marrow. End stage osteomyelosclerosis. Well, what causes this? Andrew spoke about the genetics and the mutations that can be acquired. And yes, we know that that is a problem, and therefore patients are now more aware and want to be tested, as one of the in the audience asked in the question. But what's causing it, and when does it happen? There is a continuum from the chronic phases of the disease of ET and PV to myelofibrosis, osteomyelosclerosis, acute leukemia, bone marrow failure, and ultimately death. How long does it take? Why does it occur? And in which patients? I remember many years ago, a patient of mine rang me urgently saying it is 10 years to the day since I was diagnosed with polycythemia vera, and the doctor at the time told me in 10 years I would be progressing to myelofibrosis, and today is that day. And I had to try and reassure her that the disease doesn't happen just like that. It happens over time. It does take years, but the clock is not set, and we don't know precisely when it will occur, nor in whom. When it does occur, patients generally start to become symptomatic, as Professor DB became. There are also changes in the blood count, unexplained blood changes that are not due to the treatment. Some cells may increase in number, particularly the white blood cells. There may be a shift to more immature cells that we normally see in the bone marrow, and there may be some leukemic cells or circulating small megakaryocytes in the blood. The platelet count can also change. It may either increase or decrease, and again, not due to the therapy. And if we can't explain these changes on the blood count, we need to really consider whether it may be due to the disease progressing. We'll look at the blood film, and the changes are really those that I've already explained that can occur in myelofibrosis, with these teardrop-shaped red blood cells, an immature red blood cell progenitor or nucleated red blood cell in the blood, immature cells such as blast cells, abnormal platelets. All of these are card-carrying features of myelofibrosis, and we will know if we do a bone marrow examination, we will see the changes of myelofibrosis, which are here in words, but I think much easier to see in the bone marrow, in pictures. This is the bone marrow of a patient who had polycythemia vera, and around 20 years later, following the initial diagnosis, had those blood film changes and now has this bone marrow appearance. This looks like myelofibrosis, the abnormal pattern of the streaming of cells, megakaryocytes sitting near each other, abnormalities of the bone, very abnormal appearing megakaryocytes, and here is this streaming. And when we look at the reticulin stain overlying the two images there, a vast increase in the number of reticulin fibres, indicating or confirming the original impression that this patient has progressed to myelofibrosis. Similarly, in a patient with essential thrombocythemia who became symptomatic, the platelet count was going up, not down, so it was no longer being controlled by treatment. The megakaryocyte morphology looking significantly more abnormal than previously, very large abnormals, some streaming, clustering, and a shortage of other cell types. And again, when we did the reticulin stain, although the stain is not as dark as the previous, I hope you can see that there are fibres encasing every single cell, and in particular this cluster of megakaryocytes. So why does this happen? These are two really overt florid cases of the aggressive phase of the disease of patients who had preceding PV or ET. When does this progression start? It's certainly not on the 10th anniversary of the diagnosis. And what is the dividing line between the chronic and this aggressive fibrotic phase? Can we predict it prior to becoming overt and patient becoming symptomatic? And do patients need to have regular bone marrow examinations to detect fibrosis? And I have little doubt that the majority of you who are listening today would try and not have to have regular surveillance bone marrow examinations. I'm now going to show two other cases to show you how difficult this can be. This is a case of a patient with PV whose blood count, a 63-year-old man, normal hemoglobin, white cell count slightly elevated, and he did have a surveillance bone marrow for no particular reason other than he hadn't had a bone marrow for around 5 years. On the left is one section of that bone marrow, which to me looks hypercellular. There's an increased number of granulocytic cells making neutrophils, and an increase in the number of red blood cell progenitors and megakaryocytes. This looks like PV. But in another part of that very same biopsy from this same patient is this image, this photograph of another region of the marrow. And now I'm seeing some problems. I'm seeing too many megakaryocytes closely associated and clustering. I'm also seeing this very abnormal structure with a sinus within the marrow, and it has bone marrow cells within it. And that is another feature of myelofibrosis. When I looked at the reticulin stain of those two same regions of the bone marrow, on the left, normal pattern, on the right, increase in reticulin. One biopsy, two regions. As a hematopathologist, do I diagnose myelofibrosis? Do I tell the clinician? Do I tell Andrew his patient has progressed? Or do I tell him, you better keep an eye on Professor DB because things might be going awry? The same scenario in a patient with ET, relatively normal ET looking marrow on the left and a bit more abnormal on the right. The patient hadn't had any clinical symptoms. Hemoglobin for a female of 52 years was normal, but the patient was thrombocytotic and had a high platelet count. And again, looking at the reticulin stain of this same bone marrow, those two regions, only a mild increase on the left, a reticulin of 1, and on the right, a reticulin of 2 with these strands crossing over each other. This indicated to me that the disease was progressing, and I do report this in my bone marrow. But it does show how difficult it can be. At what point do we say there is fibrosis? I think from a patient perspective, if you've had a bone marrow test done and there is a patchy increase in reticulin and you know that there are new treatments available, I think you would probably want to know that your disease is moving. The momentum is changing. It is becoming aggressive, even though you're not yet symptomatic. And we may be able to intervene before it becomes really florid. We shouldn't wait until you are symptomatic. We should act as soon as we see a change in the momentum of the disease. So should we be doing regular surveillance bone marrows? I'm sure you will say no. But if so, how often? And some of you may be familiar with a paper that I was involved with some years ago, with patients receiving anagrelide, an antiplatelet therapy for ET, and finding the patients on that drug did have an increase in reticulin, and we weren't sure whether that was due to tablets or whether it was the disease. And our recommendation at the time was patients on anagrelide should have surveillance bone marrows done every 2 years so we could determine whether it was drug-related or the disease. So we come to the biology, which is what I was really asked to talk about, what causes myelofibrosis in MPN. The fibrotic activity is due to fibroblasts, which are normal cells in our bone marrow, and they are stimulated by inflammation. And we know that megakaryocytes are instrumental in this process. Here on the left, the megakaryocytes are increased in number and the increased reticulin on the right. There's a lot of work now being undertaken looking at inflammation and myelofibrosis. It is a potential cause. We know that there are cell hormones or cytokines that are increased in the blood in patients with fibrosis. One cell hormone that Andrew mentioned was erythropoietin or EPO. That is not a culprit, but others such as interleukin-8 or tumor necrosis factor, abbreviated TNF, are known to be associated. I now want to tell you about a very recent piece of work published in May of this year by a Cambridge group looking at elevated levels of cytokines, and in particular this one here called GRO alpha. And it was associated with higher levels, you can see in the graph down the bottom here, higher levels in patients with essential thrombocythemia, and those with the highest levels predicted progression to myelofibrosis. Now, it was thought from their work that the GRO alpha was derived from monocytes, and these are white blood cells in our blood that are involved with inflammation. So it again suggests that there is an inflammatory process. We have also done some work on Grow Alpha, and this is work that's been done by one of our students, Ryan Collinson, who's here in the room with me, and Belinda Guo, who's been leading the work, and showing that platelets in myelofibrosis have increased genetics or gene signature for Grow Alpha, and the image here on the right showing elevated Grow Alpha in the platelets of patients with myelofibrosis. Now, the data shows Grow Alpha is important in both the Cambridge study and ours, and we're going to be working with Cambridge to see what the link is. But I think an important message for you is that Australia is at the forefront of some of this work, and I wish to thank all the patients who've been involved in some of the research studies that we have been performing here. Without your contributions, this sort of data wouldn't be possible. The final piece of work that I want to briefly describe is about the megakaryocytes in marrow-fibrosis. I've already told you many times that they're very abnormal in the marrow, and they have abnormal genetics with additional mutations in patients who progress to myelofibrosis. Why does it occur? We don't really know. Can we study megakaryocytes routinely and try and predict whether a patient is going to progress to fibrosis? The answer is no, because again, you don't want to have your bone marrow test done too often. But platelets are the progeny, the sons and daughters of megakaryocytes, so can we look at platelets instead? And we have done that by looking at the RNAs, the genetic signature of platelets, and this is work that Belinda Guo published earlier this year, showing this right-hand plot. When we look at platelets and their genetics, there's a difference between normal people in blue dots, patients with ET and PV in the green dots, and patients here in the pinkish dots with myelofibrosis. So the platelets are getting an abnormal genetic profile from their megakaryocytes. And we're looking at this in much more detail now to see if we can utilise this in a blood test to try and predict progression based on platelet genetics. We're not there yet, and we don't understand all the processes about inflammation and platelets. And so for the moment, how can we predict progression? It is really patient well-being, blood count, the biochemistry test of LDH that Andrew mentioned, and the bone marrow, which I know you don't want to have done too often. Plasma markers of inflammation are probably going to become increasingly important, as are the genetics of this disease. Again, Andrew spoke about next generation sequencing to monitor and predict progression. We may be able to go further and look specifically at platelets and the RNA, the gene signature of the platelets. We're doing some new work looking at circulating stem cells that express the CD34 molecule and see whether abnormalities are in the chromosomes of those cells in the blood. So the science is progressing, and we hope that in the not too distant future we'll have some more answers for you and be able to give you some more indication as to when you may, and hope you won't, progress from the chronic to the aggressive phase of the disease along this continuum. So I will close by saying pathology has a big place in giving us an indication of progression, as I've shown you. But we're really looking at improving on the traditional features that we have used. Cytokines and genetics are both going to be important, and plugging them into personalised prediction models. We know that patients want blood tests to predict progression to disease, and we're working on it. There are a lot of people who've been involved over many years, and not all of the students who've been involved on this slide. I do wish to thank MPN Alliance Australia, the MPN Research Foundation, Ruby Red Foundation, as well as the other supporters of our work. Thank you, and I apologise for going over time. I'm happy to take questions.
Not at all. Thank you, Wendy. Wonderful presentation. First question, first cab off the rank. Should an ET or PV patient be concerned if a few teardrop cells show up in a blood test? Would this be reason to have a further bone marrow biopsy?
Teardrop poikilocytes or teardrop shaped red cells are not normal. And I think if teardrop-shaped red cells are appearing and reported in the blood film, I would be talking to my haematologist about more regular surveillance. And if having another blood count film in a month, and then another month after that, and if the cells are persistent or increasing in number, I would ask to have a bone marrow examination performed, because they really are an indicator of progression to fibrosis. They are not there normally, and they are not there as a result of treatment.
Thanks, Wendy. Next question. We've still got a few more minutes for some questions. Wendy, I'm also cognizant you've got some people in the room there with you as well. So if they have any questions, then please feel free to repeat those and answer those. So the next question is interesting around the platelet genetic studies. Do any of the therapeutics interfere with these studies or the inflammation markers?
So we have studied the platelets from a number of patients who've been on different therapies, and the results that we have achieved are independent of the treatment. In other words, the treatment does not impact, or at least to date has not seemed to impact on the RNA profile of the platelets.
Excellent. A few more questions coming through. Are there any at your end there, Wendy, that you wanted to address?
No, my group are sitting here very quietly and concentrating, and they can ask me at any time. Andrew, thank you for the offer. Happy to hand over to your group.
Wonderful, thank you. I'll also just a little reminder for people, if they want to address a specific question at one of our wonderful presenters, just do that in the question function. And also, without further ado, I'm going to hand over to Sue Taylor again to introduce our next speaker.
I'd like to introduce Professor Peter Baade, who is an experienced biostatistician at the Cancer Council of Queensland, where he oversees a program of research aimed at understanding how the burden of cancer varies over time between population subgroups and by geographical area. He was the co-lead of the award-winning Australian Cancer Atlas, has published over 250 peer-reviewed research manuscripts, and helped attract more than $12 million of external grant funding. He's happily married with 5 children, some grown up. He enjoys bushwalking, canoeing, and trying to keep their backyard in some sense of order. But the reason he's here today is to tell us something about what he's discovered about MPNs in Australia and their distribution across our country. Thank you.
Good afternoon. Thank you for the opportunity to report on how the burden of myeloproliferative neoplasms in Australia vary by where people live. Before I start, I would like to acknowledge that every statistic I mention during this presentation represents some of the large numbers of people, of individual Australians, who have and are facing the challenge of being diagnosed with cancer. If anyone does have questions about cancer or requires support, the Cancer Council's 13 11 20 helpline is a free, confidential information and support service. In comparison to other cancer types, the reporting of myeloproliferative neoplasms is relatively new in Australia. Population-based cancer registries have been recording details of cancers diagnosed in Australia since 1982. However, registration of MPNs by these registries only commenced in 2003. This meant that there was little known about how the burden of these cancers in Australia and how this burden had changed over time. So this was the rationale for publishing our paper last year that described the patterns of classic MPN in Australia. Using data from the Australian Cancer Database, we reported that there were over 8,500 MPNs diagnosed in Australia between 2003 and 2014. Of the key subtypes of MPN, about 40% of the diagnosed cases were PV. A similar percentage were ET, and about 1 in 5 cases were PMF. The diagnosis rate of classic MPNs was about 30% higher among males than females, and more common among older Australians. We found that this diagnosis burden for all MPNs has reduced over time by an average of 3% per year among males, and by less than 2% per year for females, although this was not statistically significant for females. Most of this decreasing trend was driven by reductions in PV, reducing by 8% per year among females and by 9% per year among males. In contrast, diagnosis rates of ET have been increasing in males over the same period by 5% per year, while the increase among females was again statistically non-significant. There was only a slight decrease for PMF diagnosis rates among both males and females. These changes, particularly the declining rate of PV diagnosis, are still unexplained, but they may reflect changes in clinical investigations and reporting, rather than necessarily being a true change in incidence. As is the case for population-based cancer registries, or most population-based cancer registries in Australia do not routinely collect information about genetic testing. This is important because some genetic mutations, as was noted in the earlier talk, impact how MPNs are diagnosed and treated. Being able to report complete and accurate statistics on MPNs in Australia relies on cancer registries receiving information about all MPNs in this country, including the details about the genetic information. There is a well-established association between the health and well-being of people and where they live. This may reflect the scenario where people with similar individual level characteristics tend to live in similar areas. It may also be due to the characteristics of the geographical area, such as its remoteness, the area disadvantage, how easy it is for people to access medical and other services, or even differences in the diagnosis and management processes of health conditions in those areas. To reduce the geographical inequalities and their impact, decisions about priorities and resource allocation need to be based on the best available evidence. And this includes understanding the extent and patterns of geographical inequalities in cancer. So this was the rationale for developing the Australian Cancer Atlas, which was launched 2 years ago in September 2018. The Atlas aims to show the extent of geographical patterns in cancer incidence and survival across Australia. This uses complex statistical models, which I won't go into in this talk, and novel methods of visualizing the results. Now, the Atlas is a free, interactive online system, and this is available for everyone to use by entering this web address. This project was a collaboration between Cancer Council Queensland, QUT and Frontier SI, with the support of the cancer registries across Australia, and involved a multidisciplinary team of over 40 people from these and other organisations to make this happen. The success of this collaboration was recognised earlier this year when the Australian Cancer Atlas received some prestigious awards from the spatial and surveying industry. For the Atlas, data were obtained from all 8 Australian population-based cancer registries, representing almost 2,150 small geographical areas that cover Australia. The data is currently up to 2014. However, we are planning to include data up to 2016, which is currently the latest available from the Australian Cancer Registries. We are now working towards adding MPN to the Australian Cancer Atlas. This is also motivated through discussions and support from the MPN Alliance Australia, and we appreciate their financial contribution to this work. It has required an extensive process of obtaining ethics and data custodian approvals to amend the original request for the more detailed data specifications. So the results I present in these coming slides are very much hot off the press. They are still preliminary, but we hope to incorporate these into the Australian Cancer Atlas in the next few months. We first looked at MPN diagnoses or incidents. This reflects those MPNs diagnosed and notified to the cancer registries. Diagnosis rates are adjusted for the size and age distribution of the population. This map shows how the diagnosis rate of MPN varies by geographical area across Australia. This is for males and females combined. And again, this is the data that is notified to the cancer registries. The measures are reported in terms of how they compare to the Australian average, which is set to 1. So areas in blue, those lower than 1, are where the average risk for residents is lower than the Australian average. Yellow is where the average risk is considered equal to the Australian average. And areas shown in orange or red are where the average risk of being diagnosed with MPN is higher than the Australian average. As you can see, there's a large amount of variation across the country. Diagnosis rates are lower in the western areas of the country, in Tasmania and parts of New South Wales. Conversely, some areas in Victoria and Queensland have higher than average rates of NPN. The capital city insets for Brisbane, Sydney, Melbourne and Perth are just shown to provide more details about these higher populated areas. Now, it is important to realise that these values in the map have a degree of uncertainty about them. So this is because we're dealing with small numbers in the geographical areas, and these small numbers have random variation or fluctuations. So we try and measure the extent of uncertainty with these geographical estimates. So what we've done is we've tried to interpret each geographical estimate as whether they're likely or unlikely to reflect a true difference. So the dots in this plot represent the areas, the geographical areas from the map. So the dots at the bottom of the plot have a large amount of, the dots at the bottom of the plot have a higher amount of uncertainty. So we say that they are unlikely to represent a real difference. For other geographical areas, we are more confident that they reflect a true difference from the Australian average because there is less uncertainty. This is the map for males. So the geographical patterns observed here were broadly similar to those seen for males and females combined. And then for females, although there were some minor differences, particularly in New South Wales, that will require further examination. So we can now look at the distribution of the area-specific estimates by state. This highlights a generally lower reported incidence in geographical areas across Tasmania in green, Western Australia in blue, Northern Territory in white, New South Wales in red, and Australian Capital Territory in black. And it also highlights a higher incidence in most geographical areas within Victoria in orange, and among males in Queensland, which is in yellow. We can also consider the distribution of the geographical estimates by area level socio-economic status, where areas are grouped into quintiles depending on how affluent or socio-economically disadvantaged their population is on average. So apart from some evidence among males that males living in affluent areas have a lower risk, the distributions are fairly similar. And here are the corresponding graphs for geographical remoteness. They highlight the fairly similar range of values across each of the remoteness categories, with the wide ranges likely reflecting the state and territory differences that we saw earlier. So we'll now move on to survival outcomes for Australians diagnosed with MPN. Now please note that these are estimates averaged across all patients. So they don't reflect the prognosis for a specific individual person. There is a large amount of variability. Overall, the 5-year relative survival for MPN was 81%, reducing to 68% by 10 years after diagnosis. Survival for all classic MPNs combined is generally better for females and younger Australians. Although reported often, relative survival is notoriously difficult to interpret because it ignores other causes of death. We can report survival in other ways. For example, of 100 Australians diagnosed with MPN, on average, we would expect about 29 to have died from MPN within 10 years of diagnosis. 19 of those would have died from other causes within 10 years. And 52 would still be alive after 10 years following diagnosis. Due to the statistical methods we used for these geographical analyses, rather than reporting geographical patterns in survival, we reported instead of using excess deaths due to cancer. So this means that areas with high excess deaths have low survival, and areas with low excess deaths have high survival. So excess deaths measure the deaths due to MPN within 5 years of a notified diagnosis. The geographical patterns in excess deaths among males were fairly modest, with only some suggestion of lower than average excess deaths around Brisbane and Melbourne, and slightly higher than average excess deaths in New South Wales and Western Australia. Similar patterns geographically were observed among females, with maybe some differences around Sydney and New South Wales generally, where there are higher than average excess deaths, and it's more pronounced than among males. So again, we don't know the reasons, but it's just an observation. However, we do need to be cautious when interpreting these geographical differences in excess deaths. The relatively low extent of geographical variation is further highlighted when we look at the uncertainty associated with these geographical estimates. You can see that the vast majority of estimates are in the lower part of these plots, so they are considered unlikely to represent a real difference from the Australian average, particularly among males. So we also find that there is little evidence of a difference in excess deaths by the Australian states, by the area level socio-economic categories, or by remoteness. So in summary, we found that many areas in Tasmania, Western Australia, Northern Territory, and New South Wales, including the Australian Capital Territory, had lower than average incidence of MPNs, while many areas in Victoria and Queensland had higher than average rates. There is little evidence of a difference by remoteness or area socioeconomic status, so it seems as if the key differences are by state. There is only limited evidence that survival outcomes are varied by geographical area. So whatever is impacting on the diagnosis rates doesn't seem to impact survival, and we don't know what the causes are. So I've provided a very quick summary of the overall patterns of geographical variation in diagnoses and excess mortality or survival. So where to from here? First, we aim to include these results into the Australian Cancer Atlas to make them freely available through the interactive online platform. And we hope to do this later this year, but it will be dependent on being able to get the data extract. Secondly, we want to investigate why these geographical patterns exist, particularly for the diagnosis patterns. And this will require further collaboration with other experts, clinicians, pathologists, people in cancer registries, anyone with an interest in why these patterns exist. It will also require more information, particularly about the severity of disease or diagnosis, differences in the management strategies and the notification practices in the different states and territories. So the results of these efforts could then be used to reduce the geographical variation, improve the diagnosis and reporting of MPN, hopefully, and ultimately lead to improved outcomes for people diagnosed with MPN. Thank you again for the opportunity to present these results. I'd like to acknowledge those who have contributed specifically to this geographical work, which is Jess Cameron and Lynn Fritsky. Also, the whole Australian Cancer Atlas team, the funding support from MPN Alliance Australia. And if you would like to be notified when the Australian Cancer Atlas is updated with these results, feel free to get in touch or to ask any questions after this presentation. Thank you again.
Thank you very much, Peter. Yeah, lots of questions coming through about access to the Atlas, so I'm pleased you put that email up there, so anyone who's on the presentation today can get in touch with you for some of those more specific questions. All right, now I'm just cognizant of time. We're going pretty well. We've got our panel furiously answering questions that are coming through. They're doing a power of work, Wendy and Andrew. So a huge thank you to that. So keep those questions coming. And I also want to just hand over to Ken Young from the MPN Alliance Australia to introduce our final speaker. Thanks, Ken.
Our final speaker was diagnosed with polycythemia vera in March this year, just as Australia was preparing to go into lockdown. Coming to grips with what that meant for Helen and her family was further complicated by the onset of homeschooling and various other new situations we all had to navigate in 2020. With digital communications her only means of seeking knowledge and support, Helen quickly tapped into local and international Facebook MPN communities, which in turn led her to the MPN AA, as well as the Leukaemia Foundation. She says she's extremely grateful for all her new discovered networks and credits her experience of connecting with other MPN patients as having greatly eased the weight of her diagnosis. To tell us a little bit more about this journey, I'm pleased to introduce Helen Williams.
Thanks, Ken. So my name is Helen Williams. As Ken mentioned, I've recently been diagnosed with PV. I also have not so long ago hit my half century. I'm a digital designer by profession with an academic interest in digital archiving and photo history. My husband and I live with our 10-year-old daughter and 6-year-old dog here in the inner west of Sydney. And I'm here today to talk a little bit about just my experience of being diagnosed with polycythemia vera, particularly in the context of the COVID era. So I first learnt that I had some sort of blood disorder at precisely the same time as Australia was commencing the first stages of lockdown in March this year. I changed doctors in February, and with that, my new GP had ordered a routine full blood count. Some of those results came back abnormally high, and after running the tests again, my doctor immediately referred me to the haematology department at RPA in Sydney with suspected PV. In hindsight, I've realised having those two events coincide presented in anyone's books a fairly challenging situation to contend with, but at the time I was just keeping it together. And all I can really remember about those weeks was that it was just a lot. Whilst I was relieved to finally have some sort of explanation for my deteriorating health, I also admit to feeling particularly vulnerable during a time that was already very stressful for us all. I remember my GP asking me to come in to tell me about those results. She brought up a PV info page on her computer screen, but while she was talking, I just skipped straight to the list of symptoms. I was actually quite excited to see that they read like a checklist of my own. Unfortunately, that meant I missed almost everything she said, important stuff like the name, as well as perhaps the seriousness of the news. In fact, as I was leaving, I thanked her for not telling me I have cancer, but my doctor was somewhat taken aback, and she quickly set me straight as she sent me on my way. I suspect things were a little chaotic in our hospitals in those early weeks of COVID. Certainly for me, there were delays getting an appointment at RPA, and it took me 8 weeks to have a biopsy done because they were reluctant to schedule anything more than my weekly venesections. Indeed, I was initially unable to see a specialist for almost 2 weeks, but I was desperate to know more. So as soon as I got home, I Googled. My first search spat out some terribly dismal facts about life expectancy for PV patients and a few other bits and pieces. It wasn't great. Luckily for me, the second result I opened was the information page for PV on the Leukaemia Foundation's website, which I strongly recommend for anyone who hasn't seen it already. In fact, I ended up sending a link to that page to some close family friends who wanted to know more, mainly because it gives you a calm, sensible piece of information. It's written in the Australian context and it's in plain language. So that brings me to the main theme of my talk today, which is about how important it has been for me to become well informed about PV, and with that, the importance of recognising trustworthy, evidence-based and up-to-date information sources. Even though I've been fortunate enough to find a fantastic MPN specialist whose expertise in the field gives me a lot of confidence about my treatment, sadly, you can't exactly keep your haematologist on speed dial. So I've spent the last 6 months seeking out a few other voices, ones that I can trust to fill in the gaps. As Ken mentioned in his introduction, one of the next places I looked was on Facebook to see if there are any relevant communities for MPNs and PV. Considering that I work professionally in digital marketing, that was a natural step for me. And I was pleased and surprised to discover that there were several groups to choose from. I joined Josie Muller's excellent MPN group for New Zealand and Australia, and the more specific polycythemia vera group started over in the US by Jennifer and Stephen Taylor. Even though it's true, I've occasionally felt a little overwhelmed by some of the stories I've read in those groups. I would say that both of them have provided me with a rich source of both medical and anecdotal information. Community members post links to the latest developments all the time, so it's also a great way to keep well informed about MPN research around the world. Also, I find it reassuring to read about patients who've been living with MPNs for a long time, and there's certainly a lot to be said for knowing that you're not alone. My recent connection with the lovely people at the MPN Alliance of Australia has further reinforced this. The way they've validated my relatively quick progress through the early stages of my treatment and education has been reassuring and confidence building. From a practical perspective, I've picked up quite a few helpful tips and info from other group members about a variety of PV-related issues. They've ranged from ways to ease pruritus, the dreaded itch, preparing for procedures such as venesections and my bone marrow biopsy, figuring out my bloodshot eyes has something to do with my tricky red blood cells, and feeling normal about my desire to keep track of my pathology results. It works both ways too. After asking my community if they'd ever experienced an uncomfortable tightening of their chest and stomach while running, which was a new thing that happened after I'd finished having my venesections, I discovered I wasn't alone, but that nobody could have offered an explanation or treatment. And in the end, a chance conversation with my gastroenterologist helped me to work out I was now suffering from runner's reflux. And so that information, the solution was an easy one, and I was able to feed that back into the forum, which felt good. As time has gone on, I've also worked out that because the number of PV patients is relatively small, the experience of the condition can often appear quite diverse. So it seems that the biggest challenge has often been finding answers that work for me. Of course, not all of my MPN education has been online. I have had many opportunities to talk to actual doctors, both in the flesh and via telehealth over the past few months. And those conversations have ranged from incredibly informative and helpful to not so much. So my personal experience is that PV is a real roller coaster. Just when I think I have my head around every aspect or some aspect of my treatment, I'll learn about some other new adjustment that I need to make to my daily routine. And I probably don't need to tell any of you that the way in which that news is delivered can be crucial in affecting your ability to cope with chronic illness. So honestly, I found the up and down nature of the PV news cycle very difficult to deal with in the first month or two. But one of the epiphanies I've had since then is that I have a rare disorder, and one that's not very well understood, even among many medical professionals. So I can't assume on each occasion I speak to any physician that I will hear all of the answers, and that I may not always be hearing all the right information. So now I'm learning to overcome a lifelong habit of accepting whatever my physician tells me without question. It's unbelievable how hard it is sometimes for me to query health advice, even though I know no one will ever be a better advocate for my health than me. So now, 6 months down the track, through talking to specialists, fellow patients and researching online, I have a much better understanding of my prognosis. I also know that there is a very broad spectrum of survival, and most importantly, that I can be my own advocate in my choice of treatment. At the beginning of this year, I would never have been able to envisage the sheer amount I would need to learn so that I could reach this level of confidence in my decision building. I have no doubt I still have a lot more to absorb, but I'm up to the task. So what other things have I learnt? Well, I know that eating well and exercising make a big difference to how I feel, and that I could now potentially drink water for Australia. That it may be some time before I can compete in another triathlon, and that a good night's sleep is everything, and that I will never again share a sneaky cigarette at the end of a fun night out with my mates. I know that in many ways, PV is a little bit like a game of whack-a-mole where you hammer down one thing just to have another one pop up. I know that we have a little while longer to wait for some aspects of our healthcare to enter the 21st century. I remain astonished, for example, that patients don't have a centralised online system in Australia for accessing our pathology results, and that as a patient, I must wait for results to be sent via snail mail every time I have a blood test. I have also worked out that cancer has a way of muscling in on every aspect of your life. So even though I'm still very interested in all the details of my condition, my main goal right now is to return some sort of balance to my day-to-day routine and to focus a bit more on my normal interests like running and genealogy, the arts and photography. And even though it's not something I would have wished for in 2020, lately, I've been thinking that both COVID-19 and this diagnosis have taught me to find a little breathing space in my normally busy life. And that in turn has helped me to appreciate the many other things that are positive in my world. So now my thanks go to the MPN Alliance of Australia and the Leukaemia Foundation for providing the opportunity to share my story with you. And I'd like to personally thank the other speakers today for sharing their knowledge with us. It really makes a massive difference to us all that you've taken the time to do this for us. So back to you, Andrew.
Thank you so much, Helen. I think that's such a wonderful way to finish off the session today, hearing about the lived experience. I have one question for you. There might be some people in the audience today who might have only been diagnosed, in the last few weeks or few months. If you could take yourself back to that moment early in the year, what would some of your sort of top couple of pieces of advice be for those people in the audience that might be in that position now?
Yeah, okay, well, I just think it's about gathering your team together. I think that's probably the first thing that I realised I needed to do. Obviously, I have a really supportive partner, and my 10-year-old daughter has been amazing as well. So that was the people around me. But yeah, I have gathered together some professionals. I actually do acupuncture, and I have a great acupuncturist, and there's a few little other things that I do. It's just Team Helen. I think that's probably the first thing. And yeah, and then just making sure you know who your friends are. It's true what they say. You find that out pretty quickly when this sort of thing happens. And my really good friends have been amazing. So that's probably it. And just gather the knowledge. It's really, really important to understand what it is you're dealing with as quickly as you can, I think. So yeah, crash course in haematology.
Absolutely, wonderful, wonderfully answered. Also, sort of just picking up on a couple of things you mentioned during your talk was, the themes of connection and connecting with other people that have, I suppose, walked that path that you are now walking. Do you want to talk a little bit more about that, how that came about, and some of the benefits of connecting with other people living with MPN, whether it's via Leukaemia Foundation or through the MPN Alliance?
Yeah, so well, it started, as I said, with Facebook, but that's just a great jumping off point for finding your people. And it's been surprising, actually. One of the first people I connected with was actually an old client of mine from many years ago in Melbourne, and I had just been chatting with her incidentally on Facebook and then realised I actually knew her. So those moments, and then also connecting with Sue Taylor and then the MPN AA, those have been just really, really helpful for me to suddenly regain a bit of normality. I just knowing that other people are experiencing similar things and talking about it live, that's really important too. It's just so much better than just typing out chats. I think it's been some of the talks that I've had with the MPN Alliance have just been so useful. And so I guess, yeah, I'm a talker. I really like to be able to chat. And one of the things that I found really difficult about COVID is just how we haven't been able to do as much of that. And it has happened at a time that I found I really wanted to talk to people. So I just had to make it happen whatever way I could. And yeah, it's just it's about finding people who have a shared experience, and that's really useful, I think, in just feeling better about stuff.
Excellent, thank you. I might actually we've got a few more minutes. I appreciate everyone's been on the line for quite a while. We've had it's been an amazing session. I might throw it open to the panel. Do the panel have any other questions for Helen, or any comments or other questions for other presenters?
It's Andrew here. I don't know if you can hear me. Great presentation, Helen. I noticed that itch is an issue for you, as it is with a lot of people with MF and PV.
Yes.
Have you got any tricks to help with the itch?
Great question, Andrew, and something that it's taken me a little minute to work it out, but that came purely out of the Facebook group. One thing that I've really noticed about this is that you often enter this journey without having people telling you how to deal with things like fatigue and pruritus, the itch, and just little funny things that you just can't understand why they're happening. And so being able to find out answers just in an informal way has been really useful. The Facebook group started talking very early in my experience with them about beta-alanine. And that has been my lifesaver. And in fact, it was really weird because I bought some actually because of that friend in Melbourne. And she had just sent me a picture of what she used. I was starting to have terrible itch at that point. She sent it through and then I bought it and I couldn't make it work. So I've just left it on the shelf. And then a couple of months later, I'm on Pegasus. So I noticed that it got worse when I started on Pegasus, which I wasn't expecting. So it became really intense very quickly. So I went back to the beta-alanine and I noticed people talking about it again. And one woman said, you have to have it after you eat. So I just have half a teaspoon of that after I eat in the morning, and that along with exercise, weirdly, if I run or if I walk really fast, that just clears it up. And in fact, I can actually clear the itch with intense exercise sometimes. But if I have a particularly bad session of itching, then yeah, just that half teaspoon. So I've checked with my haematologist and she says it's fine as long as I don't overdo the daily dose, which I don't. And it's just been a game changer. I really get very irritated. I have to lock myself in the room if it's bad. It's just such a horrible feeling. But yeah, that's what I've come to. I'm not sure. I'd love to hear what you have to say about that, Andrew. I've not really talked to anyone else about it, but that's been the one.
That's helpful. I mean, I have a couple of young patients that said the same thing you said, that they're trying to help themselves, so they exercise, and in the time of the exercise or shortly after it, when they're sweating a little bit, they feel better. And then, but if they cool down or they rub themselves down or they're not hydrated properly, then maybe an hour or two later they feel worse again. Even worse than before they started. So yeah. It's in that post-exercise phase. I'm interested in how to help them. If you've got any advice?
Yeah, so definitely the combination. So I'll have my exercise first thing in the morning and half an hour later after I've come home, as long as I've had that half teaspoon in a glass of water, then that will take, like I did that this morning and what is it now? It's 1:43 and I'm still fine. So that is you've got to kind of hit it with everything you can, in my opinion. And that works for me. The other thing is that I found in the winter I wear leggings to run and they are torture for me. So they just really irritate my skin. So I have been known to actually take it before I go for a run sometimes, because it's just already unbearable in 10 minutes of wearing those. But the summer I'm hoping will be better because I'll be wearing shorts. It's just crazy. It's such a funny thing to think about, but I've never had this before, but yeah, that's what it is. I hope that's been useful.
Thank you, Helen. Any other questions or last comments from anyone on the panel? I'll do my 5-second rule. I think that's it for us. I wanted to say a huge thank you on behalf of the Leukaemia Foundation and the MPN Alliance of Australia in what is Blood Cancer Awareness Month and World MPN Awareness Day for the wonderful presentations from today. We've had a mountain of questions coming through, and the presenters have done a phenomenal job of answering those queries and questions. So a big thank you for everyone who's been involved in the session today. And I think that is it, and we will leave it at that, and wishing everyone a good rest of the day.